So this talk is on neurocutaneous syndromes, and this is a new lecture that I have added for you guys because these syndromes are highly represented on the STEP exam, and so exposure to these syndromes is going to be important for you, not just from the STEP perspective, but also from doing your pediatric rotations and pediatric neurology. Neurocutaneous syndromes will be defined first, and then we're going to walk through 5 syndromes. These include neurofibromatosis 1 and 2, tuberous sclerosis, Sturge-Weber syndrome, and von Hippel-Lindau syndrome. So let's start with the overall category of neurocutaneous disorders. So these disorders are also termed phacomatoses. And phacomatoses are a heterogeneous group of disorders that primarily affect the skin and the nervous system. While they tend to be pretty diverse, they are united by their origins and defects of developing primitive ectodermal tissue. Because ectodermal tissue gives rise to both skin and nervous system, when you have mutations and genes that are related to ectodermal tissue, you will have disorders that affect both the skin and structures within typically the central nervous system. Most neurocutaneous disorders are single gene disorders. So this is a summary table of the neurocutaneous disorders, and what you've noticed, or you will notice throughout this talk, is that I'm going to highlight in red those items that appear to show up on your STEP exams that are thought to be very important. This table, pretty much the whole table is important, and that's why I've denoted it with the Step 1 icon that I've been using. So for each of these disorders, you need to know the inheritance pattern, and the majority of them are autosomal dominant with the exception of Sturge-Weber, which tends to be a sporadic mutation. Ideally, you would know which chromosome each of the genes are located on. The gene names are pretty simple except for Sturge-Weber. They're pretty much named after the disease itself. So you have NF1 and 2 for neurofibromatosis 1 and 2. You have TSC1 and 2 for tuberous sclerosis, VHL for von Hippel-Lindau, and then Sturge-Weber is going to be the GNAQ gene. Some of the proteins are also named in a way that make them easy to remember, like neurofibromin, and this particular protein, of course, is associated with neurofibromatosis. Merlin is associated with neurofibromatosis 2. It's tested on less frequently, but it is one that you'll need to know. So this slide, it appears a little bit blurry, but I don't actually want you to memorize this slide. What I want you to understand with this slide is that many of the neurocutaneous syndromes have shared mechanisms. And so this slide is kind of showing a particular pathway that many of the diseases I'm going to talk about to you today are linked to. And this particular set of pathways related disorders are mutations in genes that regulate the RAS mitogen activated protein kinase pathway, the MAPK pathway. And because they are all associated with this pathway, sometimes these neurocutaneous syndromes are called RASopathies. So this important pathway governs particular functions of the cell, such as cell growth and proliferation. It also has a role in apoptosis and differentiation. So because of the common mechanism of these disorders, many of them will have overlap in both the skin abnormalities and the central nervous system manifestations. So let's start with neurofibromatosis type 1. This was previously called von Recklinghausen disease, so you may see that show up as the descriptive name. The skin lesions in neurofibromatosis type 1, the hallmark lesions are cafe au lait spots, and that essentially is telling you it's almost the color of coffee. These tend to be spots that are located on the body that are macular and pigmented. They tend to be present at birth and grow as the individual gets older. Another characteristic skin feature in patients with NF1 is axillary or inguinal freckling. Usually this arises in the toddler years, and that's why you can see this particular patient, she's actually a girl, is holding her arm up, and you can see she's got freckling in the axillary area, which is unusual for somebody even who has a lot of freckles. There are characteristic eye findings in this disease, Lisch nodules, which essentially are hamartomas of the iris. These are very common in NF1 and occur in about 95% of patients who are older than 20. You can't typically see these with the naked eye, but you can see them on slit lamp. Even though they're present and common in patients with NF1, the patients will not have visual problems or symptoms related to this. In NF1, there are peripheral nervous system abnormalities. The most common are neurofibromas. The dermal ones, or the superficial neurofibromas, are benign nerve sheath tumors, and they occur along the length of the peripheral nerve. They tend to be non-malignant, but they can be disfiguring. And what you can see on the right, the top right here, is a picture of what these neurofibromas can look like on the skin. There's a second type of neurofibroma that we see in this disease called plexiform neurofibromas. And these occur in about 30% of patients who have NF1, and they're a bit more complicated than the dermal ones. They tend to arise from bundles of nerve fascicles or plexes, and as they grow, they become problematic because they start to erode organs, bone, vessel, or other tissues as they become larger. Now, sometimes these plexiform neurofibromas will become malignant, and in this case, they tend to grow much more rapidly and can be associated with severe pain. Patients who have plexiform neurofibromas, especially that are malignant, have a high mortality rate of 20 to 50%. So on the bottom right picture here, you can see a girl who has a plexiform neurofibroma, and it's essentially growing around the side of her face. So you can kind of see it on her neck, her lower face, and neck. And when we look at the imaging study here, we're looking at an axial cut. You can see the spinal cord is kind of down in this area, and you can see her teeth here. So this is as if we've kind of cut her right along this realm here. And what you can see over here is the tumor, and you can see it looks very heterogeneous, and it is pretty much expanding and eroding all of the bones and tissues that are over on that side of her body. Now these become a major problem because, especially in this location, they can erode into the trachea and can interfere with breathing or into the esophagus and cause problems with swallowing. So you can see how just the mass effect of these types of tumors can be an issue for those affected. NF1 is associated with several central nervous system tumors. The most hallmark classic tumor we would expect in neurofibromatosis are optic pathway gliomas, and these occur in about 15 to 20% of children with NF1. This is a grade 1 pilocytic astrocytoma, and it can occur anywhere along the optic pathway, from prechiasm to chiasm to optic tract or optic radiation, all the way back into the cortex. So what you will, actually you guys have not yet had your visual pathway lectures, so you may not know where all these locations are, but just know that the optic pathway gliomas are associated with NF1. Pheochromocytomas are also seen in NF1, but are present in some of the other diseases, so that's not going to necessarily help you with the differential. Hyperintense lesions are seen on the MRI of patients with NF1, and it hasn't quite been clear what these represent. It occurs in a very high percentage, up to 80% of patients, and they're located all over the brain, in the brainstem, the basal ganglia, the thalami, and the cerebellum. They tend to resolve by adulthood, but are believed to be maybe the cause of the neurocognitive and behavioral deficits we see in these patients. Many of these patients will have learning disabilities, and attention deficit hyperactivity disorder is commonly reported. So let's move to neurofibromatosis type 2. So this particular disease has less prominent skin manifestations than other neurocutaneous disorders. These patients will also have cafe au lait spots, about 40% of them, And they will also have these plaque-like raised hyperpigmented areas that are a little bit different in appearance to the cafe au lait spots. There are several tumor types that are associated with NF2 in the central nervous system. Spinal cord tumors will occur in approximately 70% of patients with NF2. You will see spinal schwannomas and extramedullary meningiomas as well. Because of the location of these tumors in the spinal cord, patients will have abnormalities on exam that are associated with the long tracts. They tend to have weakness and sensory changes, but they also develop pain due to the pressing of surrounding structures. If the spinal cord is involved in a large amount, you can also have bowel and bladder dysfunction. So the hallmark tumor of neurofibromatosis type 2 is a vestibular schwannoma. This is a benign tumor of the 8th cranial nerve and arises from the internal auditory canal expanding into the cerebellopontine angle. Patients will present with sensory neural hearing loss, tinnitus, balance issues, and brainstem compression. So in the upper right, we see an MRI scan, again an axial cut. If you want to orient yourself, these are the patient's ears, here and here. This is the patient's nose, and here we get a cut with a portion of the cerebellum, a portion of the cortex. And what you can see here is these bright hyperintense abnormalities, and these are sitting in the location of the cerebellopontine angle. These are most likely vestibular schwannomas. These can occur in or asymmetrically on one side or can present bilaterally. It looks like this patient has bilateral schwannomas. Cranial nerve 3 and trigeminal nerve tumors can also occur in patients with NF2, and meningiomas are quite common. The bottom picture here is a patient who has a meningioma. You can see the bright mass on this coronal section over here. Surgery tends to be the mainstay for these tumors, mostly because of mass effect and the compression of surrounding structures that can lead to compromise of breathing or other vital functions. Neurofibromatosis type 2 has some interesting genetics to it. Although it is an autosomal dominant inherited disease, there is a high rate of mosaicism. So the NF2 mutation is very frequently found in the tumors once the tumors are removed, but many times you will not actually find the mutation in a blood sample. The other issue with NF2 genetics is that about half the cases arise de novo. And so it's really important to get a genetic counselor involved who can explain some of these intricacies to the families, especially if they're planning to have additional children. If you have a patient you suspect has NF2 and you send their blood sample for genetic testing and it's negative, you may consider sampling the tumor as you may find the mutation there. So let's move into tuberous sclerosis complex. The hallmark findings of the skin here are hypermelanotic macules. These are seen in about 90% of patients who are affected, and they will appear in infancy. Sometimes you can't see these well in the naked eye, so we use a special dermatologic lamp called the Woods lamp in order to amplify their appearance. In this upper right picture here, you can see this macule that's got a lack of melanin or a decrease in melanin. Facial angiofibromas are common in approximately 75% of patients who have tuberous sclerosis. These are macular lesions in a malar distribution, and you can see that this patient here has a malar distribution of these macules, so it's very easy to recognize. Shagreen patches are common in about half of patients who have tuberous sclerosis, and they're kind of plaque-like orange peel lesions. This particular patient in the bottom picture has a shagreen patch, and you can definitely notice this abnormality on just simple visual inspection. Ungual fibromas are present in approximately 80% of patients, and these are essentially bumpy lesions on the nail bed. This particular disorder is associated with hamartomas, and it's classic to have these in the retina. A hamartoma is a focal malformation, and it tends to be related to a chromosomal abnormality, but you will see these in multiple neurocutaneous syndromes. The central nervous system is affected in this disease, and patients will clinically present in childhood or adolescence with epilepsy, autism, developmental delays, or intellectual disability. There are three main lesions that we see in this particular disease in the central nervous system. The first are the presence of tubers, and hence that's where the name tuberous sclerosis comes from. Tubers occur in 90% of patients with TS, and this is due to a problem with failure of neuronal migration during fetal development. So you essentially have congenital cortical dysplasia, and this causes epilepsy because these tubers are highly epileptogenic. And we can see these abnormalities located here, these hyperintense areas within the brain. Again, this is an axial MRI, and to orient ourselves, here are the eyeballs and the nose. This is the brainstem, this is the midbrain. If I haven't said this already, the one way you can tell it's the midbrain is it looks like Mickey Mouse. So you can see there's Mickey Mouse's eyes, and those are Mickey Mouse's ears, so you know you're in the midbrain. So what you can see here is in the cortical regions, these hyperintense areas, and this is all abnormal cortical dysplasia. So the second lesion you're going to see are subependymal nodules in 80 to 90% of patients. These are benign, and they line the surface of the ependymal lining of the lateral ventricles. So what you can see are actually the arrow is pointing out to you in the upper picture. Now the nodules themselves are benign, they don't cause problems, but they can become less benign by turning into subependymal giant cell astrocytomas. So these are neoplasms that are adjacent to the foramen of Monroe, and they become highly symptomatic by their location, especially if they grow. So in the bottom picture, what you can see is a distortion on this axial MRI cut. And what you can see is in the upper ventricles here, you can see how asymmetric they are, because you have this mass in the middle that's obstructing CSF flow and causing edema. So patients who have giant cell astrocytomas tend to have a fair amount of clinical symptoms, including headaches, nausea, vomiting, ataxia. And then patients will develop increasing amounts of irritability and lethargy as the intracranial pressure increases. Other manifestations of this disease, so cardiac rhabdomyomas are common, and renal cysts and angiomyolipomas of the kidneys can be seen as well. These will sometimes, some of these lesions will progress into renal cell cancer. So this picture on the right is this is actually a patient's kidneys, if you can believe it, and these are just prominent multiple renal cysts in that location. So there are also abnormalities found in the lungs, and no, you probably don't need to know that particular word for your step exam. And of this page, probably the angiomyolipomas are going to be the highest yield to remember for the kidneys. Tuberous sclerosis can actually be treated by mTOR inhibitor medications, and if you remember that these common mechanisms that the neurocutaneous syndromes have, this is quite promising for these patients. They can be put on rapamycin or everolimus, and these medications can improve overall the manifestations of the disorder. Sturge-Weber is also termed encephalo-trigeminal angiomatosis. This particular neurocutaneous syndrome is distinguished by the fact that it is a vascular malformation syndrome, and it tends to involve small capillary-sized blood vessels. It is a progressive disorder, and unlike some of the other neurocutaneous syndromes, it becomes problematic even as you get older. So the classic skin lesion of Sturge-Weber is this facial port wine birthmark. It's a capillary malformation, and it typically occurs in the ophthalmic branch of the trigeminal nerve, although frequently the second branch is involved as well. So in the upper picture, you see a child who has a port wine stain that's involving the upper two divisions of the trigeminal nerve. Hers is a little bit less pigmented than the adult who's below. And you can see that the adult below has some vascular abnormalities that are causing some swelling and other kind of deforming features of her face. So this can occur in patients who have a port wine birthmark. So I think many of you have seen somebody who has a port wine birthmark, and you now know and can identify them readily when you're out and about. You can say to your friends and family, oh yes, that patient has Sturge-Weber or encephalo-trigeminal angiomatosis, and sound quite intelligent and that you're spending your medical school tuition for something very worthwhile. Lesions of the eyes are also common in Sturge-Weber syndrome. Patients tend to have choroid angiomas and glaucoma. Central nervous system lesions are common in Sturge-Weber. They tend to be vascular lesions. So you have abnormal intracranial leptomeningeal blood vessels. They tend to be frequent in the parietal occipital region, and they're almost always ipsilateral to the port wine birthmark. So if the birthmark is on the right side, you would expect an abnormality in the right cortex. So the problem with these lesions is that they disrupt normal cerebral blood flow, and that leads to neuronal loss. This picture in the lower right has an arrow that shows you where those abnormal blood vessels are in the leptomeninges, and you can see that they're a little bit bright and enhancing compared to the other side. Clinical features in Sturge-Weber syndrome: epilepsy occurs in 80% of these patients, stroke-like episodes. There are headaches with migrainous features and developmental delays. There are some treatments that you want to consider for these patients. Laser treatment can be quite helpful to reduce the severity of the port wine birthmark. And many of these patients will be put on aspirin to prevent vascular ischemic events such as stroke in patients who have the leptomeningeal blood vessel issues. So the last disorder we're going to talk about is von Hippel-Lindau syndrome. The skin features of this disorder are angiomas, which are cavernous hemangiomas in the skin, mucosa, and organs. So if you look at this child in the picture on the top, what you can see is that the lesion looks a little bit different, right? This is very different than a cafe au lait spot. This one looks much more vascular on the surface, and that's what you're going to expect to see in von Hippel-Lindau. In the eye, we see hemangioblastomas in the retina, which are highly vascular and have hyperchromatic nuclei. This is a picture, this lower picture on the right is exactly an hemangioblastoma looking in past the optic nerve onto the retina, and you can actually see a little bit of blood in that particular lesion. Pheochromocytomas are also common in von Hippel-Lindau, and patients can have renal cysts and renal cell carcinoma. So the characteristic central nervous system of this disorder is hemangioblastomas. They very commonly occur in the cerebellum, and that's what you're seeing here. So just to orient you again, we're looking at axial MRI scans. We can see this patient's eyes and nose in the top of the picture. And in the bottom of the picture, we're seeing the cerebellum and we're seeing the brainstem. We're kind of at the level of the pons here. So the arrow is pointing out the beginning of the hemangioblastoma, and as you move into B, it starts to grow, and in C, it's actually got some cystic characteristics now. So that is the last slide of this deck, and I just want to reiterate that what you will need to know from this particular lecture are the things that I've highlighted in red and that I have said will show up on your STEP exams. So there's a lot of kind of long words and different tumor types in this talk, and it's very likely you will come back to this at some point when you're learning tumors in oncology, but you can use this as a reference at that time.